This weekend we have an airway conference where there's 100 dentists learning about sleep disorder breathing problems in children and in adults. And I'm very lucky to have two of the speakers here speaking with me today. We have Dr. Gillian Dunlop, who's a pediatric ear, nose and throat specialist who's in Wahroonga.
Yep.
And we have Dr. David McIntosh, who's up in the Sunshine Coast. I just thought I'd chat to them a little bit about the link dentists have with ear, nose and throat doctors from your personal experience. Gillian made a really good comment today. She said, I seem to be getting more referrals from dentists than I do from general medical practitioners.
Yes, I think it's because the dentists are really involved with the kids' mouths. The dentists are looking for disease, and I find that GPs have to look after the whole child, but the dentists have a special interest, and it's that special interest that makes sure that these kids don't get missed.
Now, David, you and I have talked for many years about malocclusion as maybe a predictive factor of sleep disordered breathing. As you know, I'm just about to publish my PhD research. 3,500 kids. We took the time to take standard orthodontic records, but we did something different. We actually got a PSG on these kids. And what do we find? If you're looking just for OSA, maybe 30-35%, which I thought was high.
Which is quite high.
When we start looking at the whole spectrum of sleep disordered breathing, 92%.
Yeah, no one has got a lot of experience in terms of kids turning up to an orthodontist and using that as the starting point to say how many of them have got a breathing problem or an ENT problem. And when you look at the research that's out there, it's 40 to 80% of children, if they are assessed, will be found to have an airway problem. People, will argue very religiously about does airway cause, malocclusion and all those sorts of things. And, part of that argument to me has never really mattered. And whether one causes the other or not is irrelevant to the fact that that kid's got two problems.
Yeah, absolutely. Dr. Dunlop, can you tell us a little bit about the type of behaviour you see in these kids?
These kids destroy your room.
Well, absolutely.
The concentration span is really poor. You give them a toy to play with and they'll play with it for a little while, and then they're on to the next and the next and the next. And if you ask these parents, everybody in the house is sleep deprived because these kids are getting up in the middle of the night and climbing into mum and dad's bed.
Yes.
The older kids I find are much more emotionally fragile, and I tend to see the boys get aggressive and the girls get tearful. I'm talking about 7, 8, 9-year-olds, but the little ones really have very poor, very short concentration span.
One thing I'd recommend to anyone watching this podcast, Dr. Dunlop has an amazing video which he's put together. Can you just refer back to your website so people can watch that?
Yeah, and look for the video called Kids and Sleep Apnea. I made it several years ago because really there isn't a lot of information out there for parents and practitioners. So I thought, well, I'll make that information, put it all together, and have videos of kids before and after surgery, so you can see the symptoms and you can see what happens after the surgery and how the kids are so much better.
Great for parents, absolutely fantastic. David, if I can turn attention now, because the topic here is dentists possibly being gatekeepers of the airway, right?
Absolutely.
I see a lot of misdiagnosis of ADHD. Do you want to share your insights on that?
We can actually subtype ADHD into 5 different categories. 5 different categories. And a big part of that category is kids with sleep disordered breathing. And we know, and probably the first paper that came out was around about 2006, where they had kids diagnosed with ADHD, sent to ENTs, where they had the big tonsils, big adenoids, taken out 12 months later. ADHD diagnosis gone in all of them. Not all of them, but we also know that where they do have both, that it's true ADHD and sleep disordered breathing, their need for medication is less. Because you basically have this synergistic effect of poor sleep on top of the neurodevelopmental issues of ADHD. So either way, the child's better. They're either better because it was never ADHD, or they're better because it is, but they don't need as much medication to control their symptoms.
Win-win either way. The audience you're talking to here are mainly dentists, but of course a lot of concerned parents, who have that troublesome child and are sort of looking for solutions.
Yeah, look, I sort of run the hashtag of, hashtag don't ignore the snore.
Very good.
But we just go back to basics, you go back to, what we knew 100 years ago. Mouth breathing, snoring, stopping breathing at night, those 3 things, not normal. There's no equivocating. They need to see a specialist.
Great. I loved your comment today on Bruxism. Because, we as dentists just assume anyone who Brux is stressed use. And you have that great analogy that, if you see someone hitting their head against the wall, to try and help them, you're going to either give them a pillow, which is just going to cushion their hitting, or you're going to try and stop them from doing the procedure.
Work out why they started doing it.
We as dentists give someone a splint, and many dentists out there would know our patients crying through the splint. What's your thoughts on bruxism in children?
Yeah, look, bruxism is a symptom. It's been thrown around as a diagnosis, but it is a symptom. And you have to look for the underlying cause. And I have obviously a biased view with regards to the patients that I see, because the dentists send me the bruxing kids that have an airway problem, but that's the thing you don't want to miss, because we know 80% of children that are grinding their teeth where there's an airway problem will stop doing it completely once the airway problem is fixed. It's a physiological rather than a psychological type of stress, and it's a physiological stress response to low oxygen levels.
If you take a video of your child when they're sleeping, show it to the general practitioner, I think they'll listen more. So if you're a dental practitioner, give that advice to the parent, and hopefully one day that kid will get to an ENT.
Every second kid I have has some form of allergic rhinitis. Dust mite is the big one. Any tips for parents and for dentists on how to control that side of things? Because again, it may not be obstructive sleep apnea, but the constant open mouth posture for these kids is affecting things.
I think the one practical thing you can do is treat the allergy. The easiest thing is just to give the child antihistamines every day for 2 weeks. And if the child's better, well then you know allergy's playing a role. And you can think about things like desensitization. If you desensitize a child, well, you'll have them drug-free for about 10 years. And that'll get them through their teens where their allergies at their worst.
Fantastic. Well, that wraps up another podcast, and we look forward to chatting again on another topic in another location.